And welcome to the 193rd episode of the 988 Crisis Jam. I'm Megan Haupt. I'm Chief of Staff for the National Association of State Mental Health Program Directors. Today, our feature presentation is on CCBHCs and the crisis response. And thrilled to have David Voursney, who is the Director of Division of Community Behavioral Health for SAMHSA's Center for Mental Health Services. And we'll get to that in just a moment. We got a few housekeeping pieces. Let's turn to those. Wonderful. This is the page you go to register for the Crisis Jam. If you're watching this by YouTube, this is where you would go. And you can see it in the chat box, how to get to this page. You can register, you can see past episodes, you can see videos, materials. This is the place to go. So really thrilled for that. Thank you, for having that. And I'm gonna move to the latest crisis news, Crisis Con, which is taking place in Phoenix, Arizona, October 14th through the 17th, coming right up. And Heather Honaker, right?
Got it.
Okay, wonderful. Who is president of the Crisis Residential Association. If you want to tell us a little bit about this.
Yeah, thanks, Megan. Hi, everyone. I'm Heather, president of the Crisis Residential Association. We are so excited to be co-hosting Crisis Con with the International Council for Helplines next week in Phoenix, Arizona. It's so hard to believe that it's already here. We are so excited about our lineup of keynote speakers. We have Monica Johnson joining us, Rick Griffin from the Neuro Leadership Academy, and Kevin Hines, who we all know and love. We have over 80 workshop sessions that cover the crisis continuum, so there's something for everyone. As you can see on this slide, we are sold out. There's a join waitlist button. So we have about 875 attendees joining us from over 40 states and 3 different countries. Many of you on this call will either be joining to attend or presenting, speaking with us. So we're just thrilled to have you. Looking forward to meeting you all next week. So if you see me around the property, please say, hey, I want to meet you and hear about the important work you're doing in your communities. And then lastly, if you are interested in helping out at all with Crisis Con, planning for 2025 and 2026 are well underway, and we would love to have you involved.
Heather, thank you so much. How exciting. What attendance.
Yeah, we are
Wow.
pumped about it. Thank you.
Wonderful. Well, I know people are looking forward to that. Thank you very much. And now we're gonna just talk about some of the latest news. There's an NPR exclusive on U.S. overdose deaths plummet, saving thousands of lives. And the real question there is why? Why is there a decrease? There's about roughly a 10 to 6%, 10.6% decrease, which is great news. And this comes from CDC data, but it is intriguing and hopeful. So great. And there's a link in the chat related to that. And also the National Association of Counties, otherwise known as NACO, has put out a report messaging to support a behavioral health continuum of care, rural and frontier county leaders. So we encourage you to take a look at that. Great. And now we're going to go to the crisis trivia hot seat. Abby Bridgers, are you on? Abby is
yes.
Wonderful. Crisis 988 data analyst for the Maine Department of Health and Human Services. Abby, thank you so much for being on. You were not in the green room, so she does not know the answer. Okay, right? You don't know the answer.
That's true. I know.
Okay, you were not there. Okay. Like, I don't know what the question is yet. Okay. So, Certified Community Behavioral Health Clinics, or CCBHCs, was first established as a demonstration project under the Protecting Access to Medicaid Act of 2014, PAMA. The first CCBHCs began operations in 2017. Which of the following services is not typically required to be provided by a CCBHC? A, crisis mental health services. B, outpatient mental health and substance use services, C, inpatient psychiatric hospital care, or D, screening, assessment, and diagnosis. And so participants, you all have a poll that is up, so please choose through the poll. And Abby, what do you think this might be?
I think C, inpatient psych.
Okay, are you sure?
Not at all, Meg, not at all. No,
Okay.
no.
Have you ever seen My Cousin Vinny, that movie?
I haven't.
Ah, okay. Well, it's Are You Sure? Okay, anyway, that's a New Jersey thing. The so do you want to call on a friend or check with the audience?
Let's see. Maybe, can I see the poll results? Oh yeah, okay, so it's overwhelmingly C, so I will lock in my initial guess, which is C. 90% is solid from the data.
Okay, we're gonna go with C. Great. So let's take a look. Excellent. Abby, you trusted yourself. That's awesome. So CCBHCs are required to provide a comprehensive range of outpatient mental health and substance use services, but inpatient psychiatric hospital care is not typically a required service. They often coordinate with inpatient facilities, but do not provide this level of care directly. So way to go, Crisis Jammers. Way to go, Abby. It is great to have you on, and thank you for your awesome work in Maine.
Thank you so much.
Thank you. All right. And wonderful. We're now going to move to our feature presentation with David Voursney, and again, Director, Division of Community Behavioral Health for SAMHSA Center for Mental Health Services. I'm going to turn this over to you, David. Thank you so much for being on.
Thank you so much, Megan. And thank you so much to everybody for having me on the Crisis Jam this week. Really appreciate it. I'm the director of the Division of Community Behavioral Health in the Center for Mental Health Services at SAMHSA. We house the CCBHC program for SAMHSA. We also house our work around the integration of primary and behavioral health care. So with that, I'm going to turn to my slides. I think next slide, great. So I think a lot of people here, judging by the poll results, are very familiar with CCBHCs. They got 90%. That's great. CCBHCs, I like to think, are realizing a dream that's 60 years in the making. So on October 31st, 1963, President Kennedy signed the Mental Health Services Act, and that's actually the last act he would ever sign as president. And that act supported the construction of community mental health centers around the country. But I think it was perhaps the most salient indicator or moment that signaled the shift in our country towards serving people in the community with mental illness, as opposed to serving people in institutions. And I think we all know what happened from that point moving forward. And I think that the video we started with before we got started at 12 really is a touching reminder of the importance of providing community-based services. That we really need to provide people integrated supports, but the reality is that that's not happened in a lot of places. And I think there's definitely pockets of excellence around the country and places where really good services have been provided and are being provided. But the reality is what happened after 1960 was that we developed a system of financing community behavioral health services that was reliant on fragmented financing streams and fragmented administrative systems. And there's no shock that those fragmented financing streams and administrative systems resulted in fragmented services. And so people might get excellent care in one area or no care in another, and a lot of people just fell through the cracks completely. And I'm very excited to work on certified community behavioral health clinics because I think they're one of our best chances at developing the community-based behavioral health system that our country needs. Next slide, please. So what is a CCBHC? A CCBHC brings together a comprehensive range of outpatient mental health and substance use disorder services, incorporating evidence-based practices and basing what the CCBHC does on a local needs assessment. CCBHCs provide for improved access to mental health and substance use disorder care services, including the capacity to respond to people who are experiencing crises. CCBHCs are required to serve people across the lifespan and serve people with both mental and substance use disorders. And CCBHCs must meet a set of federal certification criteria that lay out what it means to be a CCBHC. Next slide, please. So I always say, SAMHSA, we're very excited to be working on CCBHCs. We are definitely not working on CCBHCs alone. In addition to working with our state partners and people across the country who are working to implement these programs, we worked very closely with the Centers for Medicare and Medicaid Services and the Office of the Assistant Secretary for Planning and Evaluation. Very roughly, SAMHSA works on the program issues, administers the CCBHC expansion grants, which I'll talk about in a second, and oversees changes to the certification criteria. CMS focuses on payment issues, and ASPE focuses on the evaluation of our Medicaid demonstration program. But we all work together on program policy, and it's really a very close collaboration. We're in constant contact around the initiative. Next slide, please. So there's three main ways that the federal government supports CCBHCs. The original way was through a Medicaid demonstration program. And this Medicaid demonstration program started in 2017. It's administered through states. States have to complete a one-year SAMHSA planning grant, and then they're able to join the demonstration. The demonstration provides flexible and cost-based reimbursement. So instead of disconnected financing streams that has traditionally supported community-based services, this provides a cost-based reimbursement to providers to provide a comprehensive range of services at a daily or a monthly rate. It can include quality incentives, and states have an incentive to participate in the Medicaid demonstration because they receive an enhanced federal match. So they receive the match that's associated with the Children's Health Insurance Program instead of the typical Medicaid match the state receives. And we've changed the program over time. Originally, states could only have the CCBHCs in their programs they started with. We've amended the program to allow states to add additional CCBHCs over time, allowing to grow their programs. And very excitingly, under the Bipartisan Safer Communities Act in 2022, we have been able to, we're now able to add 10 new states to the CCBHC demonstration every 2 years until we run out of interested states. And I'll get to the number of states that we've reached in a second. The Medicaid demonstration is one way we support CCBHCs. We also support CCBHCs through SAMHSA expansion grants. And it's important to note that the individual CCBHCs can participate in the Medicaid demonstration and also receive our SAMHSA grants. So our grants are a little different from the Medicaid demonstration, where the state is the driver and the state is certifying CCBHCs as meeting the standards and really overseeing the CCBHCs. For our grants, SAMHSA provides $1 million in grant funding for up to $1 million for 4 years. And those funds are used in addition to the existing funding sources the CCBHC has to meet the CCBHC model, to improve their programs, and to provide for uncompensated care. We have 2 tracks in our grant program, one for new CCBHCs and one for existing CCBHCs. We administer these grants, and unlike with the state program where the state certifies CCBHCs, SAMHSA doesn't actually certify our grantees as CCBHCs. What we do is accept a detailed attestation from the CCBHCs that lays out how they meet the certification criteria. We go back and forth with CCBHCs, often multiple times, and when we're satisfied that they've provided us with enough documentation to show that we think they're meeting the criteria, that's when we will accept their attestation. We don't actually certify them as CCBHCs through our grant program. There's a third pathway that clinics can become CCBHCs and receive federal funding. And that third pathway is through states that are outside the Medicaid demonstration have created a way for paying for CCBHCs through Medicaid through another state plan option or a waiver to support CCBHCs. But those are the 3 main sources of CCBHCs. And that's helpful in understanding the next slide, which is the national reach of the CCBHC program. Next slide, please. Oh, sorry, no, never mind. The developmental timeline. So we initially authorized CCBHCs in 2014 through the Protecting Access to Medicare Act. In 2015, SAMHSA developed the certification criteria, the rules of the road for CCBHCs, and CMS developed the payment rules for CCBHCs in the Medicaid demonstration. We launched 24 planning grants across the country for states in 2016. And in 2017, 8 of those states joined the CCBHC Medicaid demonstration. In 2018, we launched our expansion grants. We got $100 million in funding to fund our grants that I just mentioned. And that funding has now grown to $385 million a year, which is great. In 2020 and 2021, Kentucky and Michigan were added to the CCBHC program. And then, as I mentioned, in 2022, the Bipartisan Safer Communities Act is giving us the ability to grow the program by adding 10 more states every 2 years until we run out of interested states. Next slide, please. And so here you can see the national spread of the CCBHC initiative. And this started out as with 66 clinics in 8 states in 2017. So this is really massive growth in a relatively short period of time. There's now more than 500 CCBHCs across 46 states, the District of Columbia, and Puerto Rico. And you can see that the 18 states that are in the Medicaid demonstration are highlighted in yellow on this slide. And the ones that are listed in blue are ones that we've just announced that are joining the demonstration just a couple months ago. And so this is very exciting for us. We announced in June, and they're going to be starting their CCBHC demonstration program. Some have already started, but all of them are going to be starting by July of next year. And so they're going to be bringing additional clinics into the initiative to increase the spread of CCBHCs. And I should just notice, I should have included this in the slide, but just 4 days ago, JAMA Network, and I think we're going to hear a little bit more about this data later, had some exciting data. They just released an article showing that CCBHCs now serve counties with over half the US population in them. And so very exciting to hear that. So a lot of the CCBHC programs in the demonstration are not statewide, but they are growing. And then the states that are highlighted in blue are states where they have received our grants, but have not are not yet a part of the demonstration. Next slide, please. So if you really want to understand CCBHCs, it's important to understand the certification criteria that govern the CCBHC system. So there are 9 required services that all CCBHCs have to deliver, and those include crisis services, outpatient mental health and substance use services, screening, diagnosis, and risk assessment, person and family-centered treatment planning, community-based mental health care for veterans, psychiatric rehabilitation services, outpatient primary care screening and monitoring, peer family support and counselor services, and targeted case management. Beyond, and each of those services is defined in the certification criteria. Beyond those service requirements, there's many other requirements that CCBHCs have to meet. So there's 6 broad areas of program requirements, including staffing. So all CCBHCs have to develop staffing and training plans based on their local community needs assessment. CCBHCs have to meet requirements which are really important in the crisis context around the availability and accessibility of services. So first of all, CCBHCs can't turn away anybody. They have to serve everybody regardless of their ability to pay or place of residence. They can charge on a sliding scale, but that's a really important factor. And again, they have to serve everybody across the lifespan, people with mental disorders, people with substance use disorders, people with co-occurring substance use and mental disorders. CCBHCs also have to provide access for timely care. So the first time someone comes in contact with a CCBHC or their family comes into contact with CCBHC, CCBHC has to determine if there's a person in crisis. If there's a person in crisis, they have to provide a mobile crisis response within 3 hours. If there's someone who has an urgent need for services, but they're not in crisis, they need to see that person the next business day. For everybody else, they have to see them within 10 business days. Within 60 business days, they have to conduct a comprehensive assessment, which then identifies the service needs across those 9 services of those people so that they should receive those services on an ongoing basis. CCBHCs also have to provide coordinated care. So they're expected to coordinate across health and social services that people receive. CCBHCs also have to develop partnerships with a range of other community agencies across the health and social service system. CCBHCs also have to have health information technology infrastructure to support that care coordination. CCBHCs have to provide the scope of services, as I mentioned on the left side of this slide here, but they have to do so in a person and family-centered manner. CCBHCs also have to engage in continuous quality improvement. And so they're expected to have a continuous quality improvement plan that specifically focuses on issues like suicide and overdose. CCBHCs also have to report on a set of quality measures that are defined in the criteria. CCBHCs also have to meet requirements around organizational authority and governance. So they have to be Medicaid providers of mental health and substance use disorders. They have to have state certification for providing mental health and substance use services. And they have to have representation of people with lived experience of mental and substance use disorders in the governance of the CCBHC. And there's specific requirements laid out in the criteria. This is a very brief description of the criteria. The full criteria about 65 pages long, but that gives you a flavor of what they cover. I'm going to talk a little bit more detail about some of the crisis requirements now. Next slide, please. So I tried to break this out along the framework that you all know. So CCBHCs have crisis requirements embedded in the certification criteria. We tried to strengthen those requirements in an update to the certification criteria that we did in 2023 and that went into effect in July of 2024. So these are now in effect across the country for CCBHCs. So When you think about someone to contact, CCBHCs are required to coordinate with the 988 contact service center serving the area that the CCBHC is located. CCBHCs have to coordinate with local emergency departments, inpatient systems, and law enforcement. CCBHCs have to educate everybody they serve about crisis planning and how to access crisis services, including 988. Someone to respond. All CCBHCs have to provide a mobile crisis contact within 3 hours. And of course, this is based on them finding out if someone's in crisis when they first come into contact with the CCBHC. CCBHCs are required to participate in their local air traffic control system, whatever that system looks like in their locality. Next slide, please. CCBHCs, with the new update to the criteria, they don't have to provide a full crisis receiving and stabilization facility. And in fact, CCBHCs can't really provide residential services as a part of the CCBHC, although many CCBHC organizations do provide residential services outside of the scope of their CCBHC. But what CCBHCs do have to do is to provide some crisis walking capacity during crisis extended hours at the CCBHC. So the CCBHCs have to provide a safe, calm place to help people de-escalate, figure out next steps if they're in a crisis during extended business hours. And I think perhaps the most important thing that CCBHCs can do for people in crisis is beyond the initial crisis response is connect them to comprehensive follow-up care. So again, CCBHCs have to serve everybody regardless of their ability to pay or place of residence. They have to provide a comprehensive set of outpatient mental health and substance use disorder services. They have to do that quickly. They have to provide care coordination. They have to do an initial evaluation, a comprehensive assessment that addresses suicide risk, substance use, overdose risk, and other safety concerns. They have to develop a crisis plan for every person they serve. They have to train their staff on suicide and overdose prevention response. And then they have to engage in continuous quality improvement, as I mentioned. Specifically, they have to address emergency department use, hospitalization, repeated crisis episodes, suicide deaths and attempts, and fatal and non-fatal overdoses. So they really have to be paying attention to how they do this better over time. Next slide, please. So some of the ways that CCBHCs are currently interacting with the 988 system, and this is from a National Council for Mental Wellbeing survey that was conducted this past year. This is 346 CCBHCs out of a sample of, I think, 395, so pretty good response rate. But 988 call centers connect with CCBHCs to dispatch mobile crisis teams in 32% of CCBHCs. There's referrals from 988 call centers to CCBHCs for post-crisis support and for 31.8% of CCBHCs. 9.5% of CCBHCs have a care coordination partnership in place with the 988 call center. And 6.1% are actually a 988 crisis contact center, which is great. And then a number of CCBHCs are working to partner with their regional 988 center. I should note that this survey went out before our crisis requirements that I mentioned, the updated crisis requirements went into effect. So we're hopeful that if you did the survey again next year, and I think they are going to keep on doing the survey, we'll see improvements over time. But the point is there's already a lot of nexus between CCBHCs and 988. Next slide, please. So I want to take you 4 takeaways from today. So CCBHCs create a federal standard floor that providers and states can build upon to meet their unique community needs in terms of providing outpatient behavioral health services to everybody who needs them. They shift the equation for providers, especially in Medicaid and the Medicaid demonstration, enabling a flexible payment that provides what people need as opposed to what they could string together based on disconnected service codes. CCBHCs can be a vital part of the crisis containment of communities, providing immediate crisis response after a call or a contact, and then also providing guaranteed access to continuing care. And then finally, there's just been a lot of growth in CCBHC since 2017, and we're hopeful to see more growth as the years continue, following on the expansions under the Bipartisan Safer Communities Act. So I'm very excited to be here again, and I think we have a couple of very knowledgeable discussants who are going to talk a little bit about CCBHCs now.
David, thank you very much. Wow. And it's really neat that it's evolved, you know, that the criteria has been revisited and then updated and put in context for how things are moving. And there are some questions in the chat, but I wanted to bring Carrie Slatton-Hodges on. Carrie is the Senior Behavioral Health Advisor for the National Association of State Mental Health Program Directors. Carrie, can you give us your comments and reflections?
Yes, well, thank you so much for that presentation, David. And I have to say, it's we are like-minded in that community behavioral health services are so incredibly important, and the continued growth and iteration of those to allow people to have lives within the community is so incredibly important. And you mentioned the Community Mental Health Center Act that was signed into law in the 60s as really the beginning of our development of how people can receive care in the communities. And I will say, from having worked in community behavioral health for 30-something years, the most significant change that I have seen during my time is the CCBHC system and its development across our nation. And there's a number of reasons why it is so important that I want to mention. One is the national criteria for what all of us should have to be able to meet the needs of persons within our states and within our communities. So setting those expectations for all of us of what is appropriate and what is needed to provide the best care across the nation. Second to that is the flexible financial structure that comes with CCBHCs. As we know, across states, there are, as was mentioned, fragmented ways that behavioral health is supported from a financial perspective, where the CCBHCs is one of the first times in so many years that we have the opportunity to cover the cost of providing excellent care. And that is so critical. And it's very, very critical as we're talking about crisis care. Because if you can imagine, in order to provide the best crisis care across our states and across our nation, we have to have the availability 24/7, 365 for the support people who have crisis needs. And that is so challenging, if not impossible, to do on a fee-for-service system, because you have to have that infrastructure in place throughout that entire time period in order to support people's needs. And that fee-for-service structure does not fully support that from a financial perspective. So what I can say is, when CCBHC is combined with developing a comprehensive crisis system, it becomes sustainable, it becomes doable, and it allows communities to have the type of crisis care systems that we imagine and we envision. Now, CCBHCs are thought of as being federally defined and supported, but then coming down to the state being more state specific. So you have criteria that is developed from a national perspective, but when you bring it down to the state level, states are able to develop their own certification processes that address unique needs and challenges within each individual state. States also then are able to review cost reports to make sure that costs are reasonable and that are supporting the types of services and systems that they want to see across their state. Now, I'm going to bring it a little more specific to Oklahoma, where I was able to implement CCBHCs across that state, to let you know how incredibly important CCBHCs are in the development of crisis care. So through this model, we were able to develop safe places for people to walk in 24/7 across the entire state who are in need of a face-to-face service anytime, any day. And this wonderful set of CCBHCs within our state stepped up, supported by this model, to be able to have those available for all. Now, in addition to that, the coordination of care with 988, as 988 has developed and grown, is so incredibly critical. So that coordination to where when 988 systems have a caller who either is in need of a mobile crisis immediate contact, that is able to flow through a CCBHC system so that those services, which are requirements of CCBHCs, are able to get out into the community rapidly. But as was mentioned, what is so critically important is the coordination of that care after the 988 call. So we have resolved the immediate crisis, but what we want to do is continue to work with you for improvements in your life and in your ability to manage your life in the best way possible. And that is really what CCBHCs bring to the table, and it is such a game changer. And the last thing I will say is I feel like CCBHCs really put behavioral health on par with physical health, and that the cost of providing excellent care can be supported through these initiatives, and therefore lift us all up and lift our system up all across the nation. So thank you for your time. With that, I'm going to turn it over to Lauren from Compass Health to tell us a little bit about the work that she is doing in Missouri. So Lauren?
Yes, thank you, Carrie. And thank you all for sharing your time today. So Lauren Moyer, I'm an Executive VP at Compass Health Network, and I'm also our state's 988 Task Force Chair. So, there was a question posed in the chat that someone would like to speak to someone who is a CCBHC as well as a 988 Crisis Call Center. And I will just put my hand up to volunteer to provide that perspective, but also knowing that our perspective in Missouri, we're really kind of all the things. So our 988 Crisis Call Centers, we have about 6 of us. Half of us are CCBHCs and crisis call centers, and half of us are crisis call centers that are working very closely and collaboratively with all of our CCBHCs throughout the state of Missouri. And one reason I think that has really helped us truly create the ideal crisis system of care, which was kind of the ultimate goal with the rollout of 988, is that we've all realized that we work better together and that we have to do it in coordination and real strong, true collaboration and linkage to ongoing care to really make an impact, especially with our first responder services. So when we started our journey with 988, we really came to the table to say, we want to teach our children the difference between when to call 988 and when to call 911. And so I really do feel like that has been the trajectory that we've all kind of been in the headspace of saying, like, how do we do this all together? So, from that first call to getting them routed, and more importantly, getting them connected to that ongoing care. And that takes work. So we all meet routinely a few times a month where we're all kind of coming to the table to share what our barriers are. The familiar callers between all of our state, the familiar faces between all of our state. And really, how do we make sure that we're connecting with one another? How are we having a really warm handoff to that mobile crisis response? How are we ensuring they're getting that residential substance use bed? And maybe staying in that, crisis stabilization center for a little past those 23 hours of stabilization. So we're really just trying to work better together, and acknowledging that some of us have all the resources under one umbrella, but like, how can we continue to connect each other? So we do have kind of that air traffic controller infrastructure that we have really been focused on building and creating in the state of Missouri. And we have just kind of identified that as Mo Connect, so like Missouri Connect. And it's basically just an IT platform that helps all of our 988 crisis call centers be able to speak to each other in the moment, and then be able to speak to all of our CCBHC providers who are the mobile crisis response in the moment as well, and making sure that they have real-time data of what the situation is. Our larger goal with that system is to make sure that our behavioral health crisis centers are added to that. Our residential substance use beds are added to that. And perhaps later down the road, even getting our hospital inpatient beds added to that platform so that we can truly avoid that unnecessary emergency room visit and maybe go from behavioral health crisis center straight into that inpatient psych, if that's the level of care necessary. But I really do just want to hit on everything that Carrie said. It's really an unprecedented time for us as CCBHCs to really embed these core crisis services. We've really been band-aiding all of these gaps that we've inadvertently created over the past decades. And CCBHC, the PPS model of reimbursement, really helps us as a center be able to support that ongoing effort and work. So having been one of the people who opened up the original Behavioral Health Crisis Center back in 2015 in the Kansas City, Missouri area, I was always told that will be shut down after the 10 years of seed funding. And I can talk with you all today to say we are in line to have 24 of those crisis stabilization centers in Missouri. And that is because of CCBHC and really having the business acumen to build up that PPS model. So thank you, and happy to support anyone who's trying to do the same thing.
Lauren, thank you very, very much. And thank you, Carrie, for both of your very thoughtful comments, the collaboration and the relationships that need to happen, and the resulting sustainability out of this model. So fantastic. I do want to note in the chat box a paper that Dr. Minkoff is highlighting that he was co-editor. Take a look at that. The link is there, hot off the presses. And thank you very, very much. Great. Let's move to the SAMHSA update. And we have Dr. Belina Shaw, who's the Senior Medical Advisor for SAMHSA Center for Mental Health Services. Dr. Shaw, it's great to have you on. Go ahead.
Thank you. Hi, Megan, and hi, everyone. Hi, Corinne. So I am here to do the SAMHSA update. Just can't thank David, Voursney enough, Carrie, Lauren. We had the opportunity to visit Lauren's excellent operation, and not just from the perspective of the CCBHC and really that, I think that we talk about the CCBHC being a base and a floor as with respect to the criteria, but then also just such opportunity to grow and flourish. And Compass has done that. Carrie has done that statewide in Oklahoma, and we're just so thankful to be able to see the CCBHC movement growing. And I just want to thank also personally David, our CCBHC champion. I've said it many times before, but to be able to be in government and see such a dramatic change in system development and just in a program that's expanded in this way and is really, I think, a disruptor to care as usual is just really important. And I just thank David for his leadership. And then Ken mentioned also the CCBHC crisis paper that I'm sure has a much better title, but was written through the National Council, which also provides the technical assistance at both the state and individual level for the CCBHCs, supported by the Medical Directors Institute. SAMHSA does participate in that as well. So of the National Council. So we're just really excited about the work that's being done. Although not a formal SAMHSA product, we did provide some input and were participants and helped to fund the meeting that spearheaded that activity. So with respect to other updates, a couple of other ones I wanted to mention. Number one, we had yesterday an event at the Humphrey building, the main Health and Human Services building, that was focused on emergency room boarding, that was sponsored by AHRQ, the Agency for Healthcare Research and Quality, had a bunch of other federal agencies there, all of your usual players, that most of which David mentioned earlier, but really started to think about we're continuing to think about this problem of ED boarding and broader solutions. Of course, in the behavioral health work group, I was there with my little nipping dog bells and whistles to say crisis, crisis, crisis. And so hoping that we will continue to see the recommendations come out of that symposium and that summit to highlight the need for additional crisis care. There are a couple of other updates I also wanted to mention, and I know many of you have heard of, and we've mentioned that we are updating the national guidelines, so the 2020 national guidelines. We are in the process of updating those, as well as updating and also creating a dictionary, a guide to really codify the standards and definitions for crisis systems and services. Lauren and her model in Missouri looks different than, say, the model in Arizona, and they're all great for creating a comprehensive system, but we want to make sure that we are clarifying distinctions so that first of all, people who are receiving care can know what they're receiving and getting, can help to standardize care provision, and then also eventually lead to better payment broadly, not just from Medicaid system, but making sure that we have buy-in from our commercial payers, but they have repeatedly told us that we have to know what we're paying for first. And so this is our goal, is to figure out what these services are. And we'll be stratifying the standards and definitions. And so I wanted to mention that because there will be an opportunity for public comment for all of these documents. And I wanted to make sure that you guys are keeping your ears out, and we will disseminate that information through this group as well. But just wanted to give a little preview and let you know that that's there. And also one of the other levels of care that's going to be clarified and codified is the behavioral health urgent care, which, as you guys now know, is part of the CCBHC criteria as that stabilization service. So just excited for all of these. There's a lot of work going on. There's also a mobile crisis toolkit that's going on in the background too. But we just wanted to give you those main highlights. So the ARC work with the emergency room boarding and the three documents, the two that I wanted to highlight today. Thanks, Megan.
Thank you so much, Dr. Shaw. SAMHSA just does such great work, and we just really appreciate all that you do. We are now going to move to Carrie Slatton-Hodges from NASHBID. Go ahead, Carrie.
Yes. Since we're on the theme of CCBHCs today, I wanted to point out that as we've talked about CCBHCs, one thing to keep in mind that CCBHCs are not just a program over here separate in and amongst itself, but CCBHCs really become an overarching structure by which the rest of our work across states can be done. And that can include things such as supported employment and how we develop that throughout our states, and to help support persons in recovery. And that not only is a key component of CCBHCs, but CCBHCs are a way to lift and continue to do that work and sustain that work within states. As well as that, when we talk about early intervention in psychosis and serious mental illness, again, can be a part of the overall structuring of CCBHCs. With the care coordination that is built within CCBHC, it becomes a perfect model to develop and sustain those evidence-based practices around first episode psychosis. Now, I say these things because these are initiatives that NASHBID works on every day in partnership with SAMHSA and on behalf of SAMHSA, and also in partnership with National Council to continue the growth and the development of CCBHCs and the implementation of these evidence-based practices within this model. So whether you're talking about supported employment, early psychosis, or the role of peers and the change agents that peers can be across all of our models, Those are all of the things that can fall up under the overarching umbrella of CCBHCs, but are all things that are near and dear to NASHBID and that NASHBID works on every day to help you across the state learn more about these initiatives, how you can be supported in these initiatives with training and learning opportunities ongoing all the time. In addition, I want to mention NASHBID's TTI projects that are under review currently for the next round. Again, a SAMHSA supported and funded initiative to help states further develop the work to help bring community-based services further into life, to continue to improve, and really to make it the reason that we get up and do this work each and every day. So I am thankful to be a part of NASHBID, who continues to support all of you and the work that you're doing. But most importantly, I am so grateful, and NASHBID is so grateful to be a part of the community whose goal every day is to better the work that is done across our nation on behalf of persons needing support and assistance. And again, with CCBHCs being a component of that, but also being an overarching structure where all of this evidence-based work can be done and lifted up across our nation. So thank you.
Carrie, thank you so much. You bring so many fabulous perspectives and so much depth. So thank you very much for your remarks. We are now going to go to the data corner. Amanda, I'm going to pronounce your name Maury. Is that right? Amanda
Perfect. Mallory. Yeah, that's great.
Maui. You know what? You and I do the same thing. AU, right? The owl.
Yeah, exactly. Yes,
I gotcha. I gotcha.
Uh,
So wonderful. And I believe you did an article on CCBHCs, which just makes it so relevant that you're on right now. Please go ahead.
Great. Thank you so much for being for allowing me to speak today. Just an amazing lineup of speakers, and I'm really thrilled to be a part of. So before jumping into the paper that I wanted to talk about, which is oh, I didn't realize there was animation on this. If you wouldn't mind just clicking through to the end of the slide. Great. That should be it. Perfect. So it's just the previous one. Oh, can we go back to, great, perfect. I wanted to share quickly another paper that just came out on CCBHCs that David mentioned, that shows just the growth in the geographic access to CCBHCs over time, where we see that today, as David said, over 60% of CCBHC, or 60% of the population resides within a county served by CCBHC. I'm happy to talk about this paper more to anyone that might be interested in it. But today I came here to talk about another paper that looks at CCBHC crisis services, and I'll shoot it in the chat as well. And I don't have time to talk about everything that's in here, but there's one finding that I really want to highlight. But just to get us started on what we did in the paper, is we were really interested in identifying factors associated with two aspects of CCBHC crisis services. So first, we wanted to figure out what factors were associated with whether or not a CCBHC offered services directly versus through another organization, which in this case, they're called designated collaborating organizations, or DCOs. And the second question is, we wanted to figure out whether or not what were the factors associated with whether or not CCBHCs added crisis services after becoming a CCBHC in order to fulfill CCBHC criteria, or in comparison to clinics that had already offered these services before receiving CCBHC designation. And to answer these questions, we combined two what I think are really cool data sets. So first is, we've already talked about the National Council and the amazing work they do on CCBHCs, but we use their impact survey data, which is a survey they conduct on the universe of CCBHCs. And then we combine that data with another data set on CCBHC service areas. And what we have in this data set is we track which counties fall within CCBHC service areas over time. So it's a really rich data set that I'm happy to discuss with anyone who might be interested in it. Next slide, please. Thank you. And I think we need to move through again. Perfect. That's it. Great. So the the main finding that I wanted to talk to you today, it relates to CCBHC Medicaid bundled payments. So David mentioned these in his slides. So depending on how an organization becomes a CCBHC, they might be eligible for these special Medicaid bundle payments that come in the form of a per diem or monthly rate. And for reference to David's slides, the financing mechanisms here, either through the Medicaid demonstration or the state plan amendments or waiver approvals. So what we find is that clinics that are getting these special payments, these special Medicaid payments, were more likely to have added mobile crisis response and crisis stabilization services after CCBHC designation in order to fulfill the criteria than clinics that did not receive this payment. Now, our data doesn't allow us to figure out, why we see this difference and when clinics added these services by CCBHC Medicaid bundle payment status, but we have some suspicions as to what might be going on. And what we suspect is that it reflects the structure of the CCBHC Medicaid bundled payment. So the main goal of these payments is really twofold. So the first is to address historic shortfalls in Medicaid payments for community mental health providers. And then the second is to provide a more sustainable financial foundation to both launch and sustain the resource-intensive CCBHC criteria. And the way it goes about doing that is through the structure. So in that first year, the payment is based off of the anticipated costs of fulfilling CCBHC criteria. And then the rates are rebased using historic actual costs. And what we think is that these payments might be fulfilling their intents and that they're providing clinics that didn't already offer these services the financial resources needed to both launch and sustain more resource-intensive CCBHC services, in this case, mobile crisis response and crisis stabilization. Now, what does that mean from a policy perspective? Well, we suspect that it might mean that these Medicaid bundle payments might be a lever available to us to increase the availability of crisis services or some crisis services around the country. Though, and this is a major limitation of the analysis, is our data by no means allows us to assess whether this potential increase in availability is sufficient to meet all the growing crisis care needs around the country. And with that, I'll move to the next slide. And just want to say thank you so much. Here's my email and the citation for the paper I just talked about. Feel free to reach out if you have any questions or any thoughts about our work. Thanks.
Thank you so much, Amanda. What a great article, really intriguing. And so please access that information if you are on and watching this. We're now going to move to Peer Central with Arrow Foster. Arrow, go ahead.
Thank you. And this really is an exciting discussion for me today. As someone who has received care in the system for almost 4 decades, from the late 60s into the 2000s, the stuff that we have done and seen that is really accelerating this, that's happened over the last 25 years, finally to see it really come to fruition is exciting. So, and as leaders in this field, we know how essential it is that our care models reflect the needs of those we serve. And so today I want to emphasize the necessity of peer support in CCBHCs, but yet I really want to emphasize how we can address 2 of the challenges in integrating the workforce into the clinics. So we all know that peer specialists bring a unique and vital perspective to all 9 required CCBHCs, which you can see up on the screen. And I'm not going to repeat them all because David did a great job of doing that earlier. But I would say whether that is providing emotional support and de-escalation during crisis, whether that is sharing our own recovery journey and outpatient services, whether that is helping families and individuals navigate person-centered treatment planning, we act as a critical bridge between the clinical team and the people receiving care. We build trust with veterans. We guide families through complex emotions and systems and help them access communities' resources. And so whether it's coordinating care, encouraging primary health screenings, or supporting psych rehab, or walking alongside guests through the screening and diagnosis process, we offer that practical and emotional support that fosters deeper engagement in care and empowers individuals to take control of their recovery, which is a theme we have heard several times today. However, integrating peers into CCBHCs, especially new ones, comes with challenges. One of the biggest is ensuring a clear role definition and recognition of the peer workforce's value as equal contributors. It can also be difficult to balance the non-clinical role within a highly clinical environment. And many organizations struggle to create a culture that truly embraces the unique contributions that peers provide. The first step that I'm going to offer in overcoming these challenges is leadership buy-in and education. It's critical that the leaders understand the tremendous impact the peers can have on the engagement and outcomes. And this can be supported through staff training on the role, understanding the role of peers, and the value of peer specialists. From there, creating a robust onboarding and supervision process for peers is essential for their long-term success in the organization also. And this includes providing peer-specific support and ongoing professional development so that they feel really empowered in their roles. And then finally, real integration requires a culture shift. Peer specialists should be seen as core members of the care team, involved in the care planning, decision-making, and the organizational leadership. And this shift not only enhances the value of our services, but ensures that the people we serve feel heard, supported, and empowered to achieve their recovery goals, which is our goal also. So the integration of peer specialists is not just beneficial, it's essential to this model. And by addressing these challenges through education, through structural support, through culture change, we can fully leverage the transformative power of peer support and elevate the quality of service we provide. So I've mentioned 2 challenges today and some ideas on how to face those challenges. But join us here in December, right here on this jam, for a debate about the 3rd subject, and that's about peers working in the crisis field. Dr. Keat and myself will be here debating that, and more about that will come at the end of today's summit. So thank you so much, Megan, for letting me speak, and I'll turn it back over to you.
Arrow, thank you so much for your insight. There's so many positives about peers and involvement, and you just know how to talk about those challenges and how to overcome those challenges. So thank you very much. We look forward to December. And now we're going to turn it to Stephanie Hepburn to do our crisis talk and to talk about talk with Carrie Slatton-Hodges. Go ahead.
Thanks, Megan. Yeah, so I'll try to be quick. So Carrie, when I wrote this article in 2021 and interviewed Josh Cantwell of Grand Mental Health, which is a CCBHC that serves North Central and Northeast Oklahoma. And at the time, it was during the pandemic, and that was the emphasis, how the mental health iPads were helping during the pandemic. But even before that, they were helping to reach people in rural areas and reduce inpatient hospitalization dramatically. And as the former Mental Health and Substance Use Services Commissioner of Oklahoma, I wanted to get your thoughts of what was going on, those pressure points that Oklahoma was experiencing.
Yes, well, there were a number of pressure points. One in particular were that with all of the work of diversion that had been done with law enforcement, we still knew that there were too many people entering the criminal justice system as opposed to receiving treatment. And oftentimes that was because the lack of local availability for assessment and care and management of those symptoms. So one of the things that was important was to get iPads in the hand of all law enforcement across the state. And we were able to do that with Senate Bill 7. That put over 3,000 tablets in the hand of law enforcement, so that when law enforcement comes in contact with a person with mental health or addiction issues, they can immediately reach out through a button, reach a clinician at their local CCBHC, and get guidance around what to do in that particular situation. And oftentimes those tablets are handed to the person that they've encountered to de-escalate that situation, to make appointments for follow-up care. But if needed, an assessment for a higher level of care can be done right there on the tablet, and that person, the law enforcement officer, can be guided right to the local place for that to happen. What we found is that diverts more people than probably anything else that we've done from the criminal justice system. So that work has continued across Oklahoma. And today, not only with that initiative, but with the work of having tablets in consumers' hands, there's over 30,000 tablets in use in Oklahoma to help get people the care they need 24/7, to help overcome barriers such as transportation, childcare, lack of funds to get to a treatment provider. It's reduced inpatient costs. It's helped divert people from the criminal justice system and has had a tremendous effect on overall quality of care and availability of care within the state, Stephanie.
Thank you, Carrie. And I would ask people to check out the article because it also talks about having these tablets in libraries, museums, and other places in the community. Thank you for joining me. I'll pass it back to you, Megan.
Thank you so much, Stephanie, for your excellent work. And Carrie, thank you so much for all of your contributions to this call. You are just one of these experts that you're called upon and you're asked to do a lot. So thank you. So in the next 2 weeks, we have some great episodes coming up. The next one is on early intervention considerations after a suicide attempt by Dr. Stephen O'Connor. And the week after that, let's see it, is on DOJ and mobile crisis, and Jennifer Mathis will be doing that. So thank you so much, everybody. Have a great rest of your day. December is that debate on peer services for crisis, peer working in crisis care. How's that? Have a great rest of your day.